Hello everybody, welcome to our session which is exploring the nuances of non-surgical management and the evolution of pathways for identification and management of degenerative cervical myelopathy. So this hopefully will flow very nicely after all the abstracts that we heard in the previous session. We have today a few different speakers. First up, we're going to be having a video by Brett. Brett is a patient. He's a slightly atypical patient in the fact that he did have trauma before he started to present with some mild symptoms in one side of his body. Prior to the fall, he was a chef, he played squash, but you'll hear over a 3-month period how he became increasingly disabled, and there was a lot of missed opportunities for possible diagnosis. So he's really sort of highlighting the impact of DCM and keeping that at the forefront of our minds. We'll then be hearing from Leanne Wood, who is an advanced practitioner at Nottingham University Hospital and a senior research fellow, and she's going to be presenting the evolution of their secondary care pathway. And then we have Karen Outram and Christine Fraser, who are advanced practitioners in NHS Lothian, and they'll be talking about their pathways and how they've developed them. And then hopefully there'll be time for questions afterwards. So without further ado, we'll get the video up, hopefully. We only actually received the video a few minutes ago, so. Tense this.
My name is Brett Seagrave, and this is my story about living with cervical myelopathy, my journey from diagnosis through to treatment. I'm originally from South Wales, born just outside Cardiff. I now live in Lincoln, and my journey started in August 21. It was August bank holiday, and I'd been invited to a garden party down in Cornwall. I was wearing a pair of shorts at the time and some flip-flops of all things, and I went to walk up some steps, and the bottom of my flip-flop got caught on the step, propelling me forward. At the time I had 2 glasses of wine in my hand, so it was quite difficult because obviously I didn't want to spill my wine to cushion my fall. So ultimately I fell flat on my face. As you can see from the picture, that's the side of my face where I fell, where the first impact was. I concussed myself instantly, and when I came round, I thought I'd had a stroke. I didn't have any proper function in both arms. I had the most severest headache that you could ever imagine. The face was actually the least of my problems. When I got up to walk, I fell over again because my both legs just gave way, and I just couldn't comprehend what had happened. So the following day, I decided to go to Derriford Hospital, which in itself was just it was a journey in itself. I was seen by a doctor after 5 hours. He told me I needed a CT scan on my head and neck, but because I was suffering with concussion, he wouldn't give me any pain relief, which I fully understand. But I was in so much pain, and with it being a bank holiday weekend, it was chaos in A&E. After 7 hours, I'd still not been seen by anybody, so I decided to leave. Maybe in hindsight that wasn't the right thing to do, but I just needed some pain relief because I was in so much pain and nobody was seeing me. So I went to the reception and I told them that I was leaving. They said that that was fine, and you know, it was down to me. That was my personal choice. I signed a piece of paper and I left. Within an hour of returning to where I was staying in Plymouth, the doctor called and asked me where I was, and I said, "Well, I've left because I needed some pain relief." He said, "Well, you shouldn't have left. I forgot to put you on the emergency list. I'm very sorry, but please will you come back and we'll do your CT scan straight away and your next scan." So I went back to the hospital. By the time I got there, the doctor had finished his shift. So I spoke to another doctor and he wasn't aware of the situation at the time because the information had not been passed on. So after a lot of to and fro, I just decided to leave. I wasn't in a good place mentally. I was in a lot of pain. So I just decided to leave. When I got home, when I got back to Lincoln, the concussion symptoms had got a little bit better, but the pain all over my body was so painful. I had increasing numbness in my left hand side. My left hand turned into a claw, basically. I couldn't do much with it. You know, if I went to grab a drink, I would have to really concentrate on what I was doing. It wasn't second nature to me. I had pins and needles in both legs, but predominantly in the left hand side. I constantly felt like I needed to go to the toilet, and when I went, nothing would happen. In fact, I had a lot of numbness around my anus, and when I wanted to go to the toilet, it just wasn't happening for me. The most noticeable thing was my left leg dragging. It got so bad that I tore the sole off my shoe because it was dragging that much. To even step over a curb, I had to physically pull up my trouser to lift my leg. There was no the movement in my leg was non-existent. Basically, that's what I'm trying to say. My balance was really bad. If I closed my eyes, I would fall over. So over the 3-month period, I was seen in Plymouth once, Lincoln twice. I went to my GP, and it was my GP that really pushed it because he said that I needed a scan. So I went to Lincoln Hospital. They gave me a scan, and they told me that they would be in touch. 2 weeks had gone by, and nobody had been in touch. So I ran the neurology department, and they said that they would send the results to my GP. So I rang my GP, and they said they haven't received anything. I was off work. I couldn't walk. I felt sick, dizziness. As I said, my bladder. I lost control of my bladder more than once, which was not pleasant whatsoever. I had trouble going to toilet. So finally, I went to I booked an appointment with my GP. I went to see my GP. He wasn't there. I saw a locum, and he said, I just can't believe this is happening. You need to go and get you need to go to the hospital, which I did. From that scan, I was then referred to the QMC A&E department in Nottingham. I was seen by a spinal surgeon who ordered an MRI instantly. Off the back of that, they told me that I had cervical myelopathy. I really valued their opinion because for the first time somebody was straight talking to me. They were telling me exactly what I wanted to know because I knew my body wasn't right, but I couldn't rationalize it in my own mind. I was then taken into the care of the spinal team, which they were brilliant. They were absolutely fantastic. The spinal team told me I needed surgery instantly, but because of the way the NHS is currently, that this could take a while. When asked how long this could take, they said it could take up to months. And then I went home. And then over the course of the week, I lost control of my bladder, lost control of my bowels. And it was really difficult because I knew there was something wrong, but I couldn't physically do anything about it. My leg was was just dragging every time I walked. I had no power there. And so I rang QMC and they told me to come in straight away. This is where I first met Leanne Wood. Leanne was great. She was absolutely fantastic. She explained things to me in a way that was really straightforward, very concise, compassionate, understood my fears, understood what was going on with me. And then, yeah, basically I was admitted, and then I had my operation on the 8th of the 11th. So if you think that my accident was on the 21st of August, and finally my operation was in the November, it was quite a long period of time, but finally, you know, I was getting something done about it. As you can see from the slide, I had a spinal decompression, C4 through to C6. They were due to go through the front of my neck, but they told me at the time that they were going to do that. But when I woke up, they'd gone through the back. Later, when I spoke to the surgeon, I said, you know, why was that decision made? He said, because he said different surgeons have different opinions, and the surgeon that was going to do your operation didn't, and it's now me. And I decided that we were going to go through the back, which actually, in hindsight, I'm quite happy about, because, you know, nobody would really want an unsightly scar. And obviously I can't see it at the back, but that you can see there, that's where the surgery took place. I was instantly better, instantly. When I came around, the first thing I did was clench my fist. From bearing in mind where I had a hand like a withered claw, now, you know, you can see that it's working better. That it's not perfect, but it's working better than it ever did. There are ongoing issues. There were ongoing issues around neuropathic pain and getting the medication right, but I think finally we're on top of that. There are a few issues with my balance, you know, but I'm addressing that. And because the myelopathy team was so fantastic, my partner and I, we decided to run the Lincoln Half Marathon and raise money for the cause, for the charity, which I did. In that photo there, I was 17 stone. I've always been a fit and active person, but when I was immobile, unfortunately, I didn't change my diet, so the weight piled on. As you can see in that picture, I'm 17 stone there. I'm now currently 15 stone because I'm in the gym quite a lot. My goal is to get down to 13 stone. I'll probably do that by the end of summer. But yeah, and that's my journey. You know, that's where I was, where I am now. You know, there's hope at the end of the tunnel. The diagnosis took a long time, but once we got there in the end, eventually it was sorted, and my fears were alleviated. But, you know, I must thank Leanne Wood and the team at QMC, because they were fantastic. And without them, I wouldn't be telling this story. So thank you, everybody, and take care.
Unfortunately, Brett's not well today, so he was going to hopefully be here, but yeah, he's got the video instead. So I think it's really interesting hearing about his story. I think over time he has got some of the events slightly muddled. But I think the big take home there was the real delay in the diagnosis and the missed opportunities. So I think that's what we all hopefully can keep central to our mind here.
So thanks everybody. My name is Karen Uchtram. I'm one of the Spinal Advanced Practice Physiotherapists and the Musculoskeletal Pathways Lead from Lothian, and I'm here with myself and Christine Fraser, who's another one of our spinal APPs from our team, and really to talk about our journey and learning around our role in the identification and management of DCM patients within Lothian. So just to give you a bit of background to the board and our service to understand our journey better, NHS Lothian is the second largest health board in Scotland, and we've got a population of approximately 900,000. Cares delivered across 4 health and social care partnerships and acute hospital division. And historically, in relation to spinal care, we face the same quality challenges identified nationally in the Spinal Services Review Group report in 2011. And these were mainly long secondary care waits, high volume, low complexity cases within secondary care, low surgical conversion rates, care delivered in silos, and variability across pathways, diagnostics, therapy access, and patient experience. And these challenges really led us to think as a group around whether we could do things better within Lothian. This led us to thinking about the vision for care. Ideally, we wanted to deliver specialist spinal care closer to home, integrated care that involved all the key stakeholders involved in spinal services, and management based on the principles of the right care at the right person, the right time at the right place. So this vision drove us to think about our service specification, and in 2015 we launched an interface service which was originally only for lumbar spine complaints, and as part of this we developed a team of advanced physio practitioners. We developed multidisciplinary collaborative pathways of care for people with lumbar spine complaints, and the main patient group at that point was high volume, low complexity, routine lumbar spine complaints. This work proved very beneficial across the service. We audit the service annually, and what we saw over time was that we were reducing demand on specialist secondary care services and therefore freeing up their time to be able to see a quicker access, more complex and more surgical cases. Apologies for the delay. I thought I'd have my presenter notes on screen and I don't have them. So off the back of this and the success of the lumbar spine work, there was appetite to work towards a whole spine model. So in 2020, we started the work on developing cervical spine service. This was the same collaborative process where we looked at building evidence-informed pathways from the frameworks, guidelines and expert opinion, training up our already experienced team of spinal APPs to develop the required knowledge, skills and behaviours to see cervical spine conditions, and also ensuring we had the right clinical support. We're very lucky to work with the expert team and very supportive team of consultant neurosurgeons within Edinburgh, and we have a monthly one-to-one meeting with one of our spinal APPs and one of the consultant neurosurgeons. Off the back of our early work in cervical spine case, we recognised that there was a potential for higher neurological differential diagnosis within this patient group. So in addition to the support from the neurosurgeons, we also developed frequent clinical case meetings with 2 of our consultant neurologists. So, as I say, we built the service specification was the same as a lumbar spine. Again, we were looking at routine spinal interface service. So again, low complex, high volume cervical spine conditions. What we felt we needed as a service for that was a specialist APP assessment. We worked on developing access to routine diagnostics, which is important in Lothian because there's no primary care access to cervical MRI scan within the board. And again, we had the consultant support for the clinical cases. So this is a simplified overview of our cervical pathway. All cervical cases are rerouted from neurosurgery. So these are essentially primary care referrals into neurosurgery, where at the point of referral triage, they're read by a consultant neurosurgeon, and if deemed appropriate for our service, then electronically triaged to our team, and they would receive a face-to-face assessment by one of our spinal advanced practitioners. You'll see from the pathway that it was grouped into broad clinical categories, and many of these, when we were building the pathways and developing the training, were very familiar from the lumbar spine model. So obviously identification of serious pathology is there, and they would be directed onto appropriate service. Consideration of an alternative, so a non-spinal or non-musculoskeletal source, so factors such as potential peripheral nerve lesions, shoulder pathologies, vascular, visceral or inflammatory causes. Other aspects were familiar, such as non-specific spinal pain and also radiculopathy. But degenerative cervical myelopathy was a new consideration for us. And this was something we discussed at length regarding where was the value to add to the patient care. Was this right for our service, based on the fact that we were traditionally a routine service, and did we have a role within the assessment, management and diagnosis of DCM? So I'm going to pass over to Christine, who's going to talk about our journey from this point onwards around DCM.
Hi, so I'm Christine Fraser, and today I was asked to just talk about the journey that we took when setting up this DCM pathway for patients going from primary to secondary care. And this includes the decisions that we ultimately made and the pathways that we now run to. So like Karen suggested, before we came on board in the cervical pathway, traditionally all the referrals were sent from primary care to secondary care, and we kept that route in process while we did an 18-month pilot study. And the pilot study was really there to help support us clinically from the neurosurgical team and ensure the support was there, but also to make sure that the spinal APP team were able to cope with the capacity versus the demand for cervical patients. So once the referral was rerouted from neurosurgery to ourselves, it was triaged. And at the point of triage, if the clinical information included a known diagnosis of DCM, so that's either they had MRI imaging that concluded a diagnosis of DCM, or if they'd had previous surgeries. And we have access to the electronic records, so we'd also review that at the point of triage, not just the clinical information coming from the primary care clinician. If they did have clinical suspicion of progressive myelopathy or a known diagnosis, they were given an urgent appointment with us, which is in about 2 weeks' time. All others were given a routine outpatient appointment. A routine appointment with us is generally within 8 weeks. And at the initial appointment, along with the clinical information and a physical examination, we established a MGOA score. And this slide's been taken from myelopathy.org, which you'll all be aware of from today, and probably all aware of in general anyway, but they have some excellent resources on their website and some information that's well worth a review. But as you can see, the MGOA is split into 4 categories, and they look at the upper motor function, lower limb function, upper limb sensory and sphincter control. And it is graded from a 0 to 18 scale, and a lower scale indicates a more functional deficit for the patient. So when we go back to consideration of our MGOA score at point of presentation to an APP, in line with the clinical guidelines, if they had moderate or severe functional deficits on their MGOA and they had MRI evidence of diagnosis of DCM, we referred them directly back to the neurosurgical team for considerations of surgery. The referral was generated urgently via the on-call neurosurgical system if the patient had some recent progressions within their symptoms, or it was electronically and urgently sent to the neurosurgical consultants if the patient's symptoms were static over a longer period of time. However, if they were presenting without MRI evidence of a known diagnosis or recent imaging of DCM, we would then contact the on-call neurosurgical team who would support us in a decision-making on the urgency of scanning for these moderate and severe cases. For patients who had mild DCM at presentation, either with or without imaging, if they had without, we would routinely refer them for cervical imaging to confirm the diagnosis. If they had an imaging that confirmed the diagnosis but they were mild and static, we would take them to their monthly MDT meetings with our consultant neurosurgeon. And we all have one surgeon that we tend to work alongside. So at that point, we would discuss the patients with them, and they would again support our decision-making regarding operative or non-operative management. The patient's wishes at that MDT meeting would also be taken into account. We would have that discussion with the patient at point of presentation, whether they were keen to undergo or not undergo surgery. But the ultimate decision was coming down to the neurosurgeon during our MDT meetings. So although this pilot pathway was informed by the evidence and it was supported by both the neurosurgical on-call and the consultant team, and the APP showed the knowledge and experience of managing these patients, we did encounter a number of situations that made us pause and reflect upon our involvement with the diagnosis and management of these patients. And as Karen suggested, DCM was slightly different from some of the other conditions traditionally managed within the spinal APP service. They have a naturally deteriorating functional natural history, and they often go through periods of rapid progression and periods of stability. They also have a variable clinical presentation, very uncertainty within the kind of presentation and trajectory of the condition. And we were encountering cases where patients were rapidly deteriorating when they had reached the point of our clinics. But we have no access to emergency scans, and we can't admit to hospital, and we don't list for surgery. So at those cases, we were placing an unscheduled burden on an on-call neurosurgical service by asking for supported decision-making in these cases. We also don't work out of hours. So if an MRI scan we had requested was returned out of hours, there may have been a delay matching that scan to the patient's clinical presentation and management going forward. So we did question whether we were adding an additional step to these patients seeing one of our APPs rather than directly to the neurosurgical team. We also work in the community, and we are generally located in a primary care setting. So in some cases, if there was an urgent neurosurgical involvement required or an urgent scan required, the patient was often in the wrong location to receive that. That was increasing patient anxiety, and it was increasing travel concerns and difficulty getting to the right place at the right time. So with these considerations in place, I must say as well, when we also looked at a number of these cases, there was a bit of grey area on a number of them, and we all work in spinal teams, and we see that there is uncertainty within some of these DCM groups, and the kind of trajectory of these patients can be so variable. And although we have the on-call neurosurgical support for emergency on-the-day supportive decision-making, our MDTs with the consultants are monthly. And so there's a lay period in between that potentially there was grey areas of the presentation of the patient that may have had an increased anxiety for the APP of are they urgent or are they routine. We didn't have that support in the middle somewhere. So on reflection of some of these cases and discussions with our ongoing kind of teams and the neurosurgical teams, the decision was made to respond by anybody with known diagnosis of DCM or clinical information that highly suspected a progressive myelopathy. They were continued to be managed in secondary care neurosurgical services and weren't rerouted out to our spinal service. But as we've all kind of noted this morning, and probably cases that we've come across, there's a number of presentations where potentially a diagnosis of DCM has not been considered for patients' presentations, or the clinical information coming from primary care doesn't indicate any suspicion of myelopathy. But when they're presenting to us, they potentially have symptoms of myelopathy. So for these patients, we have a robust pathway in place. And where we decided we were able to add value was in the undiagnosed and unrecognised presentations of DCM. So what we have here is our launched pathway for patients with potential DCM. So these are patients who are presenting without MRI evidence of myelopathic signal changes, but potential clinical impressions in keeping with a diagnosis of myelopathy. If the patient's symptoms are long-standing and static, we continue to request a routine MRI scan, which in Lothian is about 4 to 6 weeks. If the patient is mild on their MGOA score, but they do have signs of deterioration, kind of recent deterioration over the last few weeks, potentially months, we would request an urgent MRI scan, which is about 10 to 14 days in NHS Lothian. But at that point of presentation, we would email our corresponding neurosurgical consultant that we work with so that they were aware of the case at the point that we were seeing the patient. If the patient, again, was presenting with moderate, severe or rapidly progressing symptoms, we would discuss that case with the on-call neurosurgical team, and they would support our decision-making on the urgency of scanning. If the neurosurgical team at that point had really urgent concerns, they would take over the care and they would admit the patient themselves. So once we've done the scan, in NHS Lothian, urgent scans are prioritised for reporting. So we often get the scan back within the week. For routine scans, again, approximately 4 to 6 weeks at the moment for the scan reports to come back. So once we have the MRI evidence of myelopathic signal changes along with our clinical suspicion, we then move over to the opposite side of this pathway here. We recontact the patient at that point of receiving the scan, and if their symptoms have remained mild and static, We heavily safety net them on likely progression of the symptoms and how to re-access care if they had any progression whilst awaiting any options at the moment. We would then, again, routinely take them back to the MDT meetings with the consultant for ultimate decision making on operative or non-operative management. If the decision is to non-operatively manage this patient, we commence conservative management. We give them very clear education and safety netting over probable symptoms, likely symptoms, and how to re-access the care if and when they require it. If the patients are moderate, severe, or rapidly progressing, the neurosurgical team are already aware of these patients because we highlighted them at the point of presentation, either via the on-call service or via the email to the consultant. So once the MRI evidence is there, we update the neurosurgical team and they again take over the decision making of how to manage these patients. We do have now, like I said, we don't offer out of our service. The radiology department do contact the neurosurgeons directly if an MRI scan comes back with quite concerning features that are in keeping with the clinical details that we've inputted in for the MRI report. So there is a safety net to pick up patients that we potentially are managing by the neurosurgical team, but they're actually really good because we've already highlighted them, they're aware of the case and they're excellent at picking them up and managing them going forward. So I think when we reflected on our kind of service specification and content, we had to really review where we were adding value to patients with DCM. And when we kept the patient at the centre of our decision making, their health and well-being is the most important thing. And we decided that our most added value to these patients is where we could diagnose the unrecognised DCM, those early presentations, those patients that get referred with neck and arm pain, but they come in and their gait's a bit funny, they've got tingly hands. Nobody's really considered that potentially that's in keeping with a diagnosis of myelopathy. We've all heard the ones that, oh no, that's my carpal tunnel, or no, that's my claudicant leg pain. But actually, when you put the pieces of the puzzle together, it doesn't fit in the same way that you would expect it to. Also supporting the non-operative management. If we put them in the conservative, there isn't really a robust definition of what non-operative or conservative management really looks like. But if we can give them some support in that interim period, I think that's really helpful. The safety netting and education, I think that's one of the key points that we have to make, especially in this kind of variable presentation that DCM can present like. If they aren't fully informed of their condition and they don't feel empowered to understand what's going on, they can't make the most informed decisions at critical points within their journey. And we're really well placed to have those discussions with them. But also our position within the community. I think it was kind of alluded to a little bit earlier on in one of the presentations. We're not always kind of picking up these diagnoses early enough within the community or in the primary care setting. And in Lothian, we have the GPs, but we have what we call GP APPs. I think down south they're called FCPs. So we have a lot of physios and GPs in primary care, and we have to raise awareness of these potential conditions that may be presenting early. And with our visibility, we're there formally to kind of give education to our primary care clinicians, but also informally, we're there. You know, they ask us about cases, they come to us, they talk to us, and that informal raising awareness is really helpful. We also found that during times of education with patients, when we were able to have family members or carers along, that also raises that awareness of how to manage this condition and what it's like living with a chronic and long-term condition. And I've just noted at the bottom there the kind of AO-Spine Recode DCM projects. So obviously the AO-Spine Recode DCM highlighted raising awareness and non-operative management as two of their high research priorities. And that came from clinicians as well as patients living with the condition. So hopefully with the perioperative research group and the core information set that we're all involved with, hopefully that's going to strengthen this pathway for patients, really understand and define what non-operative management looks like, but also how we can meet the expectations and the management options for these patients. But the other strengths of our DCM pathway is this ring, this neurosurgical ring. We couldn't manage our pathway without support from the neurosurgical team that we have. So it's really important that we have collaborative working between both the APPs and the neurosurgical teams. And it was in our kind of service specification that we recognised that our strengths are in the purple ring, the neurosurgeon strengths are in the green ring, the blue ring. And so once they have a confirmed diagnosis of DCM, they are much better managed in the secondary care neurosurgical services rather than within ourselves. So I think in conclusion, you know, we're all here, we all work with spinal patients, and we all have a role to play to support patients with DCM, to improve their lives, get them to the right person at the right time, and to improve awareness of early management. But the service specification that you work in will really dictate how and when you can add the most value to these patients' care. Thank you.
Right, so I'm going to talk to you about the next step. So for the patients who have been deemed appropriate or have a confirmed diagnosis of myelopathy or suspected myelopathy still, and who enter the secondary care pathway, I'm going to talk to you about what happens in our service, what happens with those patients. And this is not my pathway, this is our pathway as Nottingham University Hospitals Trust. So this has been developed by my colleagues Ellie Dunstan, Matt Dixon, Carla Evely, and Holly Clark as well. So we were all... This has really been an evolution, and I just want to talk you through how our pathways changed over time, given different constraints. So as Ellie mentioned, as Ellie mentioned earlier, talking about our hospital, Nottingham University Hospitals Trust is one of the largest teaching hospitals, supposedly in Europe. We have 1,700 beds over 2 different sites, and service a specialist population of 4.5 million people. And we have both tertiary spinal and neurosurgical services within the hospital, although traditionally DCM cases are managed by our spinal team. And our spinal team consists of 7 full-time consultants, as well as 1 consultant physiotherapist and 8 advanced spinal practitioners. To give you an idea of how busy our service is, in the last financial year, we saw over 14,000 spinal attendances in our outpatient service and 195,000 patients seen in our ED. So we're a really big, busy trust. And therefore pathways are really important to be able to standardise care and systematise it between patients and practitioners. And our spinal practitioner service has evolved over time. It's been in operation since around 2011 when we started with the elective degenerative pathway. And that was really with 3 practitioners as core. But essentially we've been seeing the whole spine since about 2014. And that has established MDTs every fortnight with 2 different dedicated consultants. Over the last 2-3 years, we've developed a scoliosis pathway and injections for nerve root blocks, so developing a competency and training package for that. And in the last 3 years, we've set up the same-day emergency care pathway for atraumatic spinal pain. And within that, we've had really close workings with the on-call team. We've got the ability to admit directly, arrange same-day MRI scans, and we work quite closely with any primary care or ED admissions. And this has really revolutionised our service as an advanced practitioner service. So we are 7 days a week. We're currently 6, but 7 days a week, 8 to 8. And we, as I say, we are accepting directly from primary care or ED, but we also have a baton phone, so therefore we often, quite often, more than we'd like to be, answering queries from primary care or interface services or physiotherapy practitioners, saying, what should I do with this patient? They are deteriorating, how do I proceed? So really being that decision maker on the other end of the line. And since 2020, when we opened, 3 months later, COVID hit, and obviously that changed services significantly. So all face-to-face care stopped. And the same-day emergency care pathway really allowed us then to bring in patients who were either suspected of deteriorating, having concerning features, or looking at triage, thinking, this patient doesn't sound like I want to speak to them over the phone, I'd rather see them face-to-face. And you'll see on the left, the tab shows that just our overall activity on our ST3, or our same-day emergency care unit, has gone up by 200% over the last 2-3 years. And you'll see on the right, it's a slide just demonstrating all our myelopathy attendances in terms of your suspected myelopathies were quite high, around 20%, so not dissimilar to our suspected chordoequino attendances, but actually once triaged and assessed and having confirmed diagnosis, only around 9 to 10% were confirmed DCM. And what's happened with our DCM pathway is that in 2017, Michael Failings and his team released the clinical guidance regarding how we should decision make around myelopathy. And in 2019, Holly and Carla looked at our myelopathy pathway in terms of those cases we were presenting at our MDTs with our consultants, and really seeing that we were presenting many cases who are mild or stable, or patient may not have wanted surgery, so almost discussing them unnecessarily. They then used the pathway that was the clinical guidance to try and develop a bit of a pathway to try and help decision make those patients and save them unnecessary waits or unnecessary reviews. And then simultaneously, our same-day emergency care pathway started and COVID hit. So the pathway changed again soon after it being developed. And to touch on what my colleagues have already just spoken about, just to run through Michael Failings' guidance, was really there's those two groups. So the one being myelopathic symptoms with confirmed cord compression, and then the other group being those patients who have confirmed cord compression but without myelopathy. And they may or may not have radicular symptoms alongside that. And essentially, the myelopathic symptoms are graded using the MJOA, so those with less than 11 points on the score are severe, those with 12 to 15 are moderate, and those with 16 to 18 are mild. And just to talk you through the guidance, those with severe symptoms and progressive should be considered for emergency surgery, but surgery is advised in this group. With moderate symptoms, again, surgery is advised, but they should be considered on an urgent basis. And those with mild symptoms, there should be having a surgical discussion. So surgery should be offered to them with an awareness of the progression with time. In contrast, those with no myelopathic symptoms but cord compression, who don't have any radicular symptoms, should be counselled regarding the onset of radicular symptoms or myelopathic symptoms. And they should really be offered a discussion around this topic. But prophylactic surgery is not recommended. Whereas those with radicular symptoms should be counselled regarding progression of myelopathic symptoms because they have a much greater chance of developing myelopathy, and surgery may be offered as a treatment alongside non-operative care. So just to give you the background for that. This was the first pathway that we developed off the back of those guidelines using our MDT service. So those who didn't have any myelopathic symptoms but did have evidence of cord compression, essentially the big thing was that we developed some safety netting. So patients were then safety netted on risks. We had shared decision making, discussing surgical versus conservative management, referred to physiotherapy for rehabilitation as appropriate, and then monitoring. So we were monitoring them for any evidence of symptom progression or whether the symptoms remained stable. And depending on that, over a 3 to 12 month period, they could, if they were stable and well safety netted and sensible enough, be discharged with cautions, alternatively be monitored or re-enter the pathway if things progressed. If they were stable but myelopathic, so with symptoms, they would then be discussed at our next fortnightly MDT. And for patients with mild symptoms, surgical consideration could be delivered in a routine manner. So you're thinking more of the longer waits here, which my colleague touched on earlier. And again, being well counselled on the risks and managed development of progression. And for those who had acute deterioration, initially they would then be referred to our on-call fellow through the emergency pathway, but once our same-day emergency care unit arose, they would then be streamlined through this pathway. And obviously with COVID, things changed. So we then had the situation where anyone who had a confirmed myelopathy on referral to our service was then being brought through to our same-day emergency care unit purely because we weren't able to see them face-to-face in our normal clinics. And those who had stable or minimal symptoms were generally being brought through our degenerative clinic, but at one point all of them came through our urgent pathway. And at this point we'd give the patient a discussion around their diagnosis with clear safety netting and information. And for those patients who chose to have surgery, who wanted to proceed with the surgical option, we then classified them into either progressive symptoms or scoring moderate to severe on the MJOA, or those with stable symptoms and mild on the MJOA. And you can see the difference between the blue ones are those who were discussed in our on-call surgical MDT, so the next day with the on-call team for consideration of emergency or urgent surgery, whereas the green is through our spinal practitioner service, which is then more every 2 weeks to 4 weeks, where they can be discussed for urgent or routine surgery. Those patients who didn't want to have surgery but had severe symptoms or mild or moderate symptoms, we then arranged a consultant review for because we felt that we needed a sign-off from the consultants, whereas those patients who had mild symptoms didn't want surgery and were happy to be monitored, we then arranged a monitoring in 3 months, then 6 months, then 12 months. And if they remained stable, they would then be discharged. And it's important to note that at this point we also arranged, as I think Ellie and Matt have both alluded to earlier in this previous session, our urgent surgical list, we ended up having a pooled list for our surgeons. So at one point, all those patients who were being listed by the practitioners were put onto 2 consultants, and their waiting list became longer and longer and longer, and therefore their urgent list was not urgent anymore. So to mitigate that, and because of the risk work that Ellie had done, we then arranged a pooled list for consultants where they were rotated, and so depending on when patients were discussed, they were spread out equally amongst all surgeons. So our pathway is different to the previous pathway you've heard about because we have access to that emergency clinic review. We had availability to be able to bring patients in on the same day or within an urgent time slot of 2 weeks, which wasn't possible in our degenerative clinic pathway. Having the pooled list of the surgeons, as I said, allowed patients to be dealt with surgically in a more timely manner. The East Midlands Spinal Network have also been doing a lot of work alongside our team for the last year, trying to develop a safety netting card for patients with confirmed myelopathy. And we've also, within our service, established more robust timelines for those who are being monitored, so in terms of having the 3 months, 6 months, 12 months. And essentially at this point, our pathway's changed again. So now on point of referral, so when we receive our triage, when we do our triage, essentially we can ascertain whether patients have a confirmed diagnosis of myelopathy with progressive symptoms or acute symptoms or a young age, and they would come through our same-day emergency care pathway with an urgent review within 2 weeks. Whereas alternatively, if they've got mild symptoms or no symptoms of myelopathy but confirmed cord compression, they would be reviewed within our degenerative pathway to a dedicated cervical clinic for patients with myelopathy, usually within a 2 to 4 week time period. And all of these patients will receive an assessment by an advanced practitioner, an MJOA score, with or without up-to-date imaging as required. And essentially, as practitioners, our role is to try and ascertain what's the risk of progression. So how old is the patient? Are they 39? Are they 75? You know, what's their radiological presentation? How severe is the radiological presentation? Is there cord signal change? Is it multi-level? What's the patient's history in terms of their symptom duration? And then really try and ascertain the assessment of stability. So how stable are their symptoms? What's happened over the last 2-month period? Have things stayed the same? Have they worsened? Is it subtle? Is it severe? And really then using the MJOA to help us grade things, but assessing the mobility as well, dexterity, things like that. And this helps us to try and decide which MDT to present the patient in, because essentially whether they wait 2 weeks for consideration of a routine or urgent surgery, which might take 3 months to, you know, in terms of urgent surgery would be anywhere around 3 months. Routine surgery, you're looking at more of a 12-month to 24-month period. Or the emergency surgical meeting where we're then considering an emergency listing or admission. And obviously we have our spinal call, the on-call team to discuss these cases with as well. So where we are really concerned about patients, we can discuss it with the on-call fellow who work within the emergency care pathway to discuss those cases as well. From a safety netting point of view, when the pathway was first developed in 2019, Holly and Carla developed this cervical stenosis booklet for those patients who had a suspicion of myelopathy but not confirmed, and we used this for a long time in our service because we didn't have anything else. So for any patient who had myelopathy or suspected myelopathy, we gave them this booklet with some information regarding symptom progression, what to look out for, what to do should any of these symptoms arise. The bottom left corner is the card being developed by the East Midlands Spinal Network. And then for those patients who we're discussing surgery with or taking to our MDTs, we try and present them with a BAS booklet, so either a web link or a paper handout of it, to try and look at the surgical options and what they might expect from that. And the success of our pathway really relies on the good working relationships we have with our surgical team. We have the ability to escalate care, so for patients who have deteriorated acutely, like you heard Brett earlier in the presentation, you know, we were able to admit direct. We could arrange same-day imaging for patients who have gone off their legs. You know, we can liaise with the surgical on-call team for those patients who are deteriorating acutely and progressively. And these integrated pathways, having both the degenerative clinic pathway, means that we can move patients back and forth between the two pathways as required, and that helps save the patient an extra step and an extra referral. However, none of these pathways are perfect in the NHS at present, and as Ellie discussed earlier in the oral presentations, many of our elective lists, so for those patients who had mild symptoms and were waiting, you know, we're on a semi-urgent surgical list, we're waiting in excess of 12 months, and there is a real risk that those patients, if not followed up, when they're on a waiting list can deteriorate. And I think that was a real awareness to us in our service that these patients shouldn't just be on a waiting list without follow-up. They should still have some sort of input or monitoring while they're waiting for surgery. Because despite being safety netted, as in all of those patients were safety netted, they didn't contact our team. And the question is how many of those patients, was it because they were older patients and didn't want to come to the hospital because of COVID? Was it because we hadn't relayed the information in a clear, an understandable way, that the impact of not contacting us was clear? Or was it that we hadn't given them enough information? So there's a real question around the quality of information we provide to patients. And it's something we'll talk about a little bit later. But what have we learned from our experience? So we've obviously had this pathway in place for quite a long time. And we'll put our hands up and say in 2019, we clearly delineated all those things that were going to be governed by how the MJOA dictated it. But for the first year or two, no one recorded MJOAs in our service. And so when we did the work around deterioration and realizing that patients were changing, we recognized that we weren't recording MJOAs routinely. And so trying to figure out how much patients had worsened was really hard. But that really enabled us to change things and everyone to become a lot better at recording things and changing our templates to ensure we all were standardized in capturing that information. There was also a real shift when we identified the deterioration in 2021, so when we did that piece of work around auditing patients on the waiting list, and helped us become a lot more aware of getting that clear baseline marker so that we could identify when deterioration had happened. And this also then changed because originally we didn't have access to the surgical on-call MDT, so we only had our fortnightly MDTs. So when we had patients who were starting to deteriorate, we didn't know what to do with them apart from try and pass them on to the spinal fellow, and there was a real grey area. And practice changed. We then had access to the next on-call daily MDT, and now it's become part of our practice where we can share between these two MDT options. I mentioned the pooled list surgeons, again, because waiting lists became too long, we had to change pathway with that. And what we've also realised is that cervical myelopathy is not a straightforward condition. And many of us had been experienced clinicians for a long time in our service. We'd been 10 years working with this patient group, and we were quite confident managing him. And we recognised that there was a real training need, that newer practitioners coming into our service weren't as confident to manage these cases in terms of assessing that stability and severity of cases. So we've changed the way that our pathway is set up in terms of our training of practitioners and what they're able to see on a daily basis. So I think that's been a real learning point for us. And so I think the other thing I wanted to bring in is from the RECODE point of view, so the international collaboration, and there's some really good work going on with RECODE DCM. There's real heterogeneity, as you can see, across different spinal pathways in different settings and different services. And at the moment, there's very little collaborative information. Certainly we don't have any cauda-equina pathways just yet from a national level nor an international level. But they do have working groups that are working to provide international consensus on both the diagnostic criteria incubators to try and improve diagnosis, the perioperative rehabilitation incubator, which is looking at both preoperative information, perioperative rehabilitation, and postoperative rehabilitation, the natural history incubator, looking at what is the natural history in more detail, and then the core information sets, which are looking at what information should be provided when patients are diagnosed with DCM. And so these things have led to some projects which are ongoing, and so hopefully watch the space because you should be contacted for surveys or to take part. But we're looking to try and gain some consensus on what diagnostic criteria are, getting consensus of what core information should be provided. We're currently doing a survey of the existing rehabilitation pathways around the UK, and developing some preoperative education guidance and development of peri and postoperative rehabilitation guidance. So these things are all underway and will hopefully make our lives as spinal practitioners a lot easier because there will be national and international guidance about what we should do. So, stop, can I do my last slide? Pathways are setting and service specific, and they may evolve with time, but having a good awareness of your own case mix, training needs and service requirements is important to optimize your pathway and tailor it to what your requirements are. Safety netting is a really important consideration, and something to, I would say, do consider for your own service what you're providing. But we should be having some tools coming forward in the future. Thank you.
Thank you very much for all our speakers. Sorry, we started a few minutes late, so we're quite tight now. We've got about 1 or 2 minutes. So if anyone does have any questions, please do ask them now. And then they're also all around for the next couple of days. So does anyone have any questions?
Hi, I just wanted to ask about the pathway that you set up in Lothian, about whether there's any capacity for your service to use technology to help you with your communication with your consultants. You were saying you only meet once a month, and I just wondered whether you could use Teams or something like that to improve that link with them.
So we do. So we set it up at our regular monthly meeting with a one-to-one consultant. There is leeway. The consultants are very easy at being approached if we wanted to, so via Teams, email, whatever, in a way that we wanted to do that. But we didn't have the formal setting, so we couldn't always guarantee the consultant's availability or a quick response that we wanted. We do have, though, coming in Lothian, which is used in our ED department, is a kind of online electronic referral system between clinicians. So if we wanted to contact the neurosurgical on-call team, we have an electronic way of doing that, so it's recorded on a patient's record rather than just a telephone call. So there are options, but definitely the formal ways that it's been set up is kind of the emergency on-call same-day discussions with the on-call neurosurgeons, or the routine discussions with the consultants at our scheduled meetings.
Hi there, can I ask Karen, Christine, thank you very much for your presentations. I've really identified with it a lot. I just wondered, the patients that go to conservative care, they are obviously robustly safety netted. Do you then monitor them like 12 months down the line or so? Or?
So again, the monitoring and the kind of advice is really guided by the neurosurgeon at the MDT. So again, depending upon the presentation of the patient, how long they've had the symptoms, what stability they have been over what length of time, we're guided on in the monitoring position. But generally, the consultants will take ownership of a number of these patients and maybe annually review them or 6-monthly review them.
Okay.
But we're supported in that decision making by the consultants. They lead that.
Thank you.
Thank you very much. And if we could thank our speakers. Thank you.